I would now like to invite Dr. Betsy O'Donnell to the stage. She's going to be giving us our lightning updates for this morning, and then we'll get started with the other presentations.
Right. Good morning and welcome back. It's great to be here for a second day of the Best of Hematology here in Vail, Colorado. Again, I want to thank the sponsors of this event and also want to thank in advance the speakers for being here today and for their presentations. That was a tough act to follow. So I am going to do my best here to be equally entertaining. But today we'll be discussing CML, ALL, AML, and MDS. This is on the heels of having discussed CLL, multiple myeloma, and lymphoma yesterday. I think we had a great time yesterday. I encourage the audience to participate. We welcome questions online. It makes it more stimulating. I am going to do my best not to slaughter the pronunciations of many of these drugs that I do not use. It has been a very humbling experience to prepare these talks and realize that what our patients must go through as they enter our world. Our first talk today will be on CML. Dr. Denninger will be presenting that. Our next talk following that will be by Dr. Kadia, and we'll be listening to a wonderful talk about ALL and AML in a fashion similar to what I did yesterday. I'm just going to underscore the abstracts that are most recent and relevant in terms of highlights. I'll begin with the ASH abstracts in AML. The first study is a phase 3 study called the ASAP trial. This is in patients with relapsed refractory AML, and it's comparing sequential conditioning and immediate allo versus intensive remission induction chemotherapy followed by allo. The hypothesis for this study was that salvage chemotherapy prior to allogeneic stem cell transplant would not provide a benefit. You can see here that patients are randomized to remission induction versus disease control, which can either be watchful waiting, low-dose Ara-C, or mitoxantrone. Next, Dr. Kadia is going to explore a number of regimens that incorporate venetoclax into their therapeutic strategy. The first is the CLIA study. This is venetoclax combined with cladribine, idarubicin, and cytarabine in induction in patients with newly diagnosed AML and high-risk MDS. In this study, you can see the treatment strategy is the classic induction with cladribine, idarubicin, and cytarabine. Venetoclax is initiated on day 2 and extended for 7 days. The next new study is an interim analysis of venetoclax in combination with fludarabine, idarubicin, and cytarabine. The VFLA study, and this is in non-low-risk AML. Here you can see, again, it's the fludarabine, idarubicin, and Ara-C. There's step-up dosing of the venetoclax, and in this study, the venetoclax is continued for 2 weeks beyond the chemotherapy. Next, we'll turn to the elderly AML population with an updated analysis of the CAVEAT trial. Here you have 5+2 chemotherapy and induction. However, there's a pre-phase of venetoclax, and then venetoclax is used for 7 days with this combination of cytarabine and idarubicin. Dr. Kadia will talk about ELN risk stratification outcomes among treatment-naive patients with AML treated with venetoclax and azacitidine. We'll also look at reduced venetoclax exposure to 7 days with azacitidine in treatment-naive patients with AML. In this study, again, these are difficult to treat patients who would not be eligible to receive idarubicin and cytarabine. Here, it's a fixed duration of 7 days of the azacitidine with 7 days of venetoclax. Then we move on to a triplet combination, azacitidine, venetoclax, and gilteritinib. In FLT3 mutated AML, gilteritinib is a FLT3 inhibitor. And then on to some novel therapies. So menin inhibitor, revumenib, leads to durable responses in patients with KMT2A rearranged or NPM1 mutant AML. This is the updated results of the phase 1 study. Oops, I think we lost a slide. Oh, well, I think I lost a slide in there. Ooh. That medication is just a phase 1 study. It's an oral medication given twice daily, and it's just a step-up dosing. The next is the phase 2 study of menin KMT2A MLL inhibitor ziftomenib. And then we'll move on to abstracts in ALL. One of the focuses of this morning will be blinatumomab. In the first study presented, we'll see a randomized phase 3 study of blinatumomab versus standard of care as consolidation for MRD negative patients. The next is looking at blinatumomab consolidation in high-risk ALL, and blina is given at week 12 as a bridge to transplant if patients are MRD positive. Then we'll look at route of administration, the introduction of subcutaneous blinatumomab. Again, we've seen such amazing results from transition to subcutaneous daratumumab. It's nice for both the patients and for the cancer center when we can do things that require less time in a chair. Then we'll look at inotuzumab, which is antibody-drug combination in MRD positive ALL. Inotuzumab for MRD positive ALL in CR1 and CR2. And then Dr. Kadia will address the question of whether adults with pH positive ALL benefit from allogeneic transplant in CR1. And finally, we'll wrap it up with a discussion of the recently published study of ponatinib and blinatumomab in pH positive ALL. For the MDS portion of this morning's discussion, Dr. Sastry will be our presenter, and she would like to review the key updates in MDS, which include updated classification prognostic systems, including the WHO and ICC classifications, the IPSS-M classification. She'll also discuss updates in low-risk MDS. She'll discuss the Medalist study. She'll go over the final data of the Sintra-Rev study. She'll present the imetelstat update as well as high-risk MDS updates. And finally, she'll go over magrolimab trial update as well as an IRAK4 novel therapy study. So the first thing that I would like to highlight is an online risk calculator that she'll present. We recently published the Pangea risk model, which is also an online risk stratification for plasma cell disorders. It's very nice clinically to be able to pull something up and be able to plug patient values in. What I like about online risk calculators is that they're easy to use. If you're not regularly seeing patients with these conditions and you can't keep those risk stratification in your head, it's nice to have easy tools available. She'll talk about this in detail. Moving on, she's going to talk about luspatercept. This is for enhancing late-phase erythropoiesis to alleviate anemia in patients with MDS. Specifically, she's going to talk about the Medalist trial, which is a 2-to-1 randomization of luspatercept for very low, and intermediate risk MDS with associated anemia. She'll also present the phase 3 COMMANDS trial, which is a randomized study of luspatercept versus EPO as upfront management of MDS. Dr. Shastri will also present the final data from the Sintra-Rev study. This was looking at low-dose lenalidomide versus placebo in patients with anemia and who are not transfusion dependent. She'll be discussing a new medication, imetelstat. We went over the pronunciation of that. Maybe the emphasis should be on the tau, as this is something that selectively targets malignant cells with continuously upregulated telomerase. This thereby induces their apoptosis, enables the potential recovery of normal hematopoiesis. The eMERGE study tests imetelstat in low-risk MDS. She'll be presenting those very exciting results. Again, we'll move on to magrolimab and azacitidine in active MDS, including patients with p53 mutated disease. And she'll characterize the responses specifically with that high-risk feature. She, too, will discuss the role of venetoclax in high-risk MDS, specifically looking at the combination of azacitidine and venetoclax in high-risk MDS and CMML. Finally, we'll focus in on IRAK4, which is a long isoform that's overexpressed in MDS and correlates with poor prognosis. This is a phase 1 study of single-agent activity in AML and high-risk MDS. So we are going to be covering a lot of different drugs, a lot of different topics. We have great presenters today, so I encourage you to sit back, relax, and enjoy these next couple talks. Thank you.